Good afternoon, everyone. We're going to be talking about the pharmacokinetics and pharmacodynamics of antibiotics, mainly in critical care. And I'm Saraa, I'm the IT assistant. So the main aim of giving an antibiotic is to make sure that you're giving the effective antibiotic and to give it at the maximum, the best dose that you can give it at, to optimize its killing and to prevent resistance. So I need to stand at the screen, sorry, I don't like sitting here. So this screen here, this side here is showing the maximized kill rate for meropenem with E. coli. And this side here on the right is showing them the minimum inhibitory concentration of killing Pseudomonas using meropenem. And you can see there's different concentrations at which they kill it. And the ones in red here is when they're unable to kill that bacteria. This is when you're getting resistance. So anything above 4 is reflecting resistance.
I will change the slide.
You can change the slide?
Yeah.
Oh, I think that's really high. And different bugs have different minimum inhibitory concentrations. Next slide. What's really important is to give the antibiotics early. The earlier you give it, the more you reduce mortality. And it's really important to give the correct dose at the right concentration, and then to select the correct antibiotic. So what this slide is showing is the volume of distribution of various beta-lactams that we use. The volume of distribution is technically the theoretical volume of volume that you need to dissolve the same amount of drug that you have in the plasma. So if it's showing that it's like 5 milligrams per liter, then, or it could be greater or less, that's the amount that you need. The higher the volume of distribution, the more it penetrates into other parts of the tissue. So with critically ill patients, this is the volume of distribution for critically ill patients in this bar that you have. With non-critically ill patients, we've got these white circles that have, that's representing their volume of distribution. So you can see in non-critically ill patients, the volume of distribution is much smaller than critically ill patients. And that's mainly because in critically ill patients, they've got their edematous, they're leaky, there's filters that we're using, and there's lots of other factors that influence the volume of distribution. And hence, when you increase the volume of distribution in a critically ill patient, you're reducing the concentration of a drug. And if you remember from the slide before, the minimum inhibitory concentration is really important because the lower the minimum inhibitory concentration that you reach, then the less effective the drug is. So after you select the correct drug, it's really important to get the right concentration. We're going to be talking about pharmacokinetics, which is basically what pharmacokinetics is what the body does to the drug, so absorption, distribution, metabolism, and elimination. And pharmacodynamics is what the drug does to the body. So that so there's time-dependent drugs that are more effective the longer they're above the minimum inhibitory concentration, and there's concentration-dependent drugs that are more effective the higher the concentration, not like those peaks and troughs are really important. And there's ones that have a mixture. So that's what we're looking for is both of them to work together. The pharmacokinetics and the pharmacodynamics work together to help optimize that antibiotic to give us the effect that we need, which is to kill the bug that we're trying to kill. Next slide, please. So this is a graph that shows concentrations against time. And some drugs actually need the area under the curve as well to be, the area under the curve is measuring the total amount of drug in your system. So drugs such as aminoglycosides, such as metronidazole, that peak effect is really important. So they're concentration-dependent killers, which is why it's really important to give higher doses and increase the frequency. So you can give it in an intermittent fashion. And then there's time-dependent antibiotics, such as the beta-lactams. And then there's ones that have a mixture, which like the fluoroquinolones, so the ciprofloxacin, and the glycopeptides. I know we give vancomycin as a continuous infusion in here, but that has both concentration-dependent and a time-dependent factor. So what we're trying to get with the concentration-dependent ones is that peak effect, and what we're trying to get with the time-dependent antibiotics is to have the longest time above the minimum inhibitory concentration. Next slide, please. Then there's a mutant selection window, and this mutant selection window is when I was taught about pharmacokinetics a long time ago, is that you have to just reach 50% of the minimum inhibitory concentration. And by reaching the minimum inhibitory concentration and not getting to the maximum concentration that you need. So usually for antibiotics, you need 4 times the minimum inhibitory concentration. So that maximum bit there is 4 times the minimum inhibitory concentration, which we need to have good efficacy for that antibiotic. If we're just hitting the minimum inhibitory concentration and we're dosing it somewhere here, you're technically selecting the resistant bugs to proliferate and killing the sensitive ones. So that's the window that encourages more resistance. And what we're trying to encourage now in new paradigm and change in thought is to go to 4 times above the minimum inhibitory concentration. So when all these drugs were tested and when manufacturers released all these licenses, the old philosophy was to just hit the MIC or just be above the MIC for like 50% of the time. But that theory is being refuted now, and we have to go a bit higher to at least 4 times. Next. Thank you. So with our patients who are predominantly septic in ICU, there's multiple predispositions that affect the pharmacokinetics of antibiotics. So first of all, we have leak capillaries, and with leak capillaries, you get an increased volume of distribution because that drug leaks to the extravascular volume that it's not supposed to go. It's supposed to go to your targeted site that it needs to go to. There's altered protein binding, so if you've got low albumin, then technically you have less, if you're protein bound, there's less albumin there, so there's more free fraction of the drug. And with more free fraction of the drug, there's 2 things that happen. There's both an increased volume of distribution, which dilutes it, and there's an increased clearance because there's more of the drug available. It's a bit of a paradox. You think there's more free fraction of the drug, hence it should go toxic, but actually the body clears more and you're diluting it more because there's an increased volume of distribution. Hang on, sorry, there's more on that slide. Then there's something called augmented renal clearance. So with sepsis, your cardiac output would sometimes increase, and when it increases, there's an increased clearance of that drug. And that phenomenon is seen mainly in critically ill patients initially, and that hence causes a low plasma concentration of the drug. There's articles that said you need to give like comoxiclav 5 times a day and tazocin 6 times a day, like ludicrous doses that I cannot put in a protocol yet because I need to see more evidence towards it. But in theory, if someone does have this augmented renal clearance, they're clearing more of the antibiotic, which is why it's really important to give the loading dose and just optimize it at the maximum dose. And when that happens, then we get treatment failure, we get antibiotic resistance. Then we get ECMO and we get dialysis. And with those, there's an extra circuit and there's extra volume going through the patient. So the extra volume, that results in increased volume distribution again. So you're diluting it. And when you're diluting the drug, you're minimizing its efficacy. Then there's certain scenarios where you're decreasing the clearance if the patient is not on the filter and their kidney is not working. Then in that scenario, there's reduced clearance and you can get toxic. But before they get to that situation, usually the decision is made to filter the patient, and hence you clear more of the drug. And that's just what end-organ dysfunction. So if your liver is not working, if your kidney is not working, then you won't be able to metabolize the drug, and hence that's the situation where you get an increase in the drug. So for your typical ICU patients, it's predominantly these situations that we see, and when they hit this scenario, then it's we have to start reducing the dose in those scenarios. So you can see most of the time we need to optimize and increase the drug because most of the situations that ICU patients go through result in a drop in their antibiotics. Next slide. Thank you. So Jason Roberts is a professor of pharmacokinetics in Australia, and he's published lots of work on the pharmacokinetics of antibiotics. And he developed this framework with the drug, the mug, and the bug. And the drug is the antibiotic that you're giving, and the mug is the patient, and the bug is the antibiotic. So we can have a local guideline that advises you on what to dose and how to dose it. And you look at things like, does it have a low or high volume distribution? Is it drug protein bind? How is it cleared? What does toxicity look like and look for it? Can we do TDM? And as you're aware, TDM that we have here is just basically just vancomycin, amikacin, I don't know. Those are the only two antibiotics and gentamicin, the aminoglycosides. Anything else goes externally and comes back 20 years later. Sorry, not 20 years, about a couple of days later, but we don't have that capacity. The Surviving Sepsis Guidelines does recommend to invest some money in TDM, and it's a work in progress that we'll get there, and then we'll be able to tailor these better. You look at interactions, antimicrobial stewardship, when we give continuous versus extended versus bolus. Then look at the patient, how sick is the patient, are they allergic to anything, how heavy are they? I wouldn't go from IV to PO, but lots of drugs have really good bioavailability, like ciprofloxacin, levofloxacin, like Nezolid and cotrimoxazole, so you can switch to the NG version if the patient is absorbing, because why do you need to like do something invasive and waste the nurse's time when it can be given NG? Look at the metabolism, whether it's renal or hepatic. Look if you're under or over treating and the risk of toxicity, so you do that balance, and look at the pharmacokinetics and pharmacodynamics in the patient context. Then the drug, we have the micro-MDT that helps us with the choice of the drug, but when you do pick that drug, when it says like Tazocin I, then it means it's intermittent sensitivity. It means we need to optimize it and give like the highest dose possible. If I could give 6 times a day, I would, but I can't right now, so just stick to 4 times a day. And TDS doesn't really cut the mustard for us in ITU. We just need to optimize it to as high a dose as we can. That's about it. Let's go to the next one. So this is the table that we created basically from Renal Drug Handbook and from literature that showed the common antibiotics that you use, and there's a few non-antibiotic drugs here like levetiracetam and tranexamic acid. But these are the main ones that you need to adjust for the filter. And then this column has the BNF dose for you. This column has those when your effluent rate is greater than 35 mils per kilo per hour. And I'll show you if it's different, you can calculate it as well. And then this scenario is really not an ITU, because by the time they hit this scenario, they usually are put on the filter. But that's, if you calculate their creatinine clearance, if it's less than 30, less than 20, and less than 10, then you can give these doses here. So we worked really hard to get this done, and hopefully I can be a bit more adventurous and get some more evidence and increase the doses there to match what's in the literature. But the literature is really scanty and really scarce. There's not much. There's like case reports that are coming out, and you can't create a guideline with case reports. So currently this is what we have to guide you guys for dosing on the filter. And this column is what you need on the filter mainly if the effluent rate is greater than 35. Next one.
Is that available anywhere on the?
So I shared it on WhatsApp, and it is available on the internet. I can find it here. I can email it again to the whole. Are you on the SHR WhatsApp?
Yeah.
I'll share it after today. Okay, so the pharmacodynamics of beta-lactam, they're bactericidal, they're slow, and they kill continuously. Ideally, optimal killing for them is 4 times above the minimum inflammatory concentration. And you can see that the kill rate here rises, and then plateaus at 4 times the MIC. And this is the MIC here. So if you're just giving a regular dose of ceftazidime, then that might not be good enough. The evidence shows that you do need to go up higher to 4 times. So there's no post-antibiotic effect with beta-lactams because bacteria will proliferate as soon as you stop the drugs. And this post-antibiotic effect we'll see next with the gentamicin and amikacins. Next slide, please. So how do you dose it? So you can, how long above the MIC do you need to be? There's different things out there in the literature, and there's a BLING-2 and BLING-1 and BLING-2 and BLING-3 trials currently going on. And unfortunately, these trials did not show any improvement in outcomes. So we're just awaiting the BLING-3 trial results to come out, and they're testing beta-lactam as a continuous infusion. And hopefully, based on that, then we can change our protocols to recommend continuous infusions. So what we currently do is the intermittent infusion, which is giving you these spikes. What other trusts have started doing is the extended infusions where they're giving like the tazocin over 3 or 4 hours, and that gives you these shorter spikes like the dotted signs. And what the theory is that you should be given a continuous infusion. With the continuous infusion, you give a bolus and then a continuous infusion over 24 hours to stay above the MIC for 4 times as long. So right now we're stuck with the intermittent infusion, but once the evidence is out there, then we can switch to what the evidence recommends. But in theory, the theory is telling us that the longer it is above the MIC, the better. So we will get there, just watch the space. Did you have a question?
Yes. Have we seen any difference in the efficiency of treatment between these 2 different types of infusions?
So the BLINK-2 trial did not show any difference in outcomes, and there's a BLINK-3 trial that's currently in progress as we speak, and based on that, then we'll be able to take the results or leave them. So because there was a negative trial that didn't show any different in outcomes, then people are like, then what's the point in changing? This is just theory. It's not going to affect the patients. So we'll just hold tight.
I have one question.
Yeah.
So is the BLINK trial limited only to beta-lactams or?
Yeah, they're mainly studying beta-lactams for continuous infusions.
And is the side effect profile any difference?
So theoretically, side effect profile, you should have less side effects because you're getting less of the peaks, because you get more side effects when you hit that peak. When you have a continuous infusion, you're minimizing the toxicity and
Guys, can you hear Saraa now?
testing 1, 2, 3. Can you hear us?
Yes. Yes. So let's go.
Yes.
Yes.
Okay.
So give me 1 second and we'll start recording again.
Next slide. Thank you. So the challenges that we have is the minimum inhibitory concentration of pathogens in critically ill patients is much higher than the rest of the population, mainly because of the kind of antibiotics they've had beforehand and the kind of bugs they've been exposed to. We also have a higher incidence of gram-negative resistant pathogens in ITU. And we have giving a time-dependent antimicrobial by continuous infusion blocks a line for 24 hours. You guys have like one central line here, another central line here. If I take a line, then the nurses will have challenges in administering more drugs. And we don't have TDM facilities as I've expressed before. Next slide, please. Thank you very much for your help, by the way. So when you put someone on the filter, how does that impact the drugs? So the main modes that we use is slow continuous ultrafiltration, and that removes just water. There's no drugs being removed. And then there's continuous veno-veno hemodiafiltration. So I'll start talking first by hemofiltration. That removes big molecules by convection. And then hemodialysis, that removes small molecules by diffusion. And CVD-HDF uses both convection and diffusion, and that removes the big molecules and the little molecules. If someone's on intermittent hemodialysis, it's just the diffusion that's going on. and those are the ones that come to BBA. But the majority of ITU patients are using the CVVH-DF dose. So if the modality of dialysis is changing, that will change the dose of the antibiotic that's being given. And you need to be a bit more aggressive with the CVVH-DF because that clears more of the drugs. Next slide. So small molecules pass easily through the membrane by diffusion and convection, and middle or large size molecules are cleared primarily by convection. And the dialysis membrane is semi-permeable. It removes solutes with a molecular weight of up to 50 Daltons. And these are the sizes. So when we look them up, like if there's a new drug that I've never heard of, I just look at how many Daltons it is, and if it comes up less than 50, less than 500, then I know that it can be dialyzed, and theoretically we can give just full dose because the filter should clear it. And if it's greater than 50, then I know that it's going to be not dialyzed at all, because it won't be dialyzed by convection or by diffusion. It will just stay in the blood. And usually that gets metabolized by the liver, and I have to look at the liver. Next slide. So this is the thing that talks about the sizes again. So greater than 20K is mainly protein-bounded albumin, too big to be filtered or cleared, and in between can be filtered, and less than 500 or less than 150, they're small and extremely well filtered. Next one. So if you look at the drug and the renal clearance is less than 30% and there's no dosage adjustment needed, you have to start looking at the liver or whatever other metabolic pathway it takes. Plasma proteins are substances that are highly protein bound will not be cleared because they're just stuck to the protein. And if you have a high volume of distribution, which is greater than 1 liter, it means that you have low clearance by the filter. We also look at something called the sieving coefficient, which measures how much comes out in a dialysate state versus how much is in your plasma. And like albumin has a sieving coefficient of 0, which means it doesn't get sieved at all. And something else like something really small would have not a casein, but yeah, the aminoglycosides would have a higher sieving coefficient. We need TDMs, which is to make sure that we're getting the right levels. And there's something called tubular reabsorption with fluconazole. So fluconazole, after it's been cleared by the liver, it gets reabsorbed back into our system. When you're putting someone on dialysis, the machine doesn't reabsorb it back. There's no tubular reabsorption. So it's one of those paradoxes with fluconazole, where we have to give higher doses on the filter, even though if you're in renal impairment, you get 50% of the dose, but if you're in renal impairment on the filter, we're not getting that tubular reabsorption that dumps it back in the plasma. So we give 800 for anyone that's on the filter because it just washes out all the fluconazole. Next slide. I think I'm duplicating what I said earlier here, so you can skip that one. Next slide. So ITU pharmacists have been baffled with all the stuff that's come out over the last decade, and we're like, what do we do with this? So someone decided to create this pseudo-creatinine clearance. And pseudo-creatinine clearance we use is, we take the effluent rate, be it 35, 45, 25, we multiply it by your weight and we divide it by 60. And that gives us a pseudo-creatinine clearance for drugs that we're not used to. So for example, a patient weighing 60 kilos, if the filter is set at 47 mils per kilo per hour, that 60 reflects like 60 minutes per hour. You do 60 times 47 divided by 60, and their pseudo-creatinine clearance for us is 47 mils per minute. So that's telling us the drugs that are renally cleared will be cleared really well by the filter. If it's something like 25, then I have to start thinking, Comoxiclav, do I start reducing the dose? Do I not? That the volume distribution is increased? From the literature and the evidence, it just shows that keep them at maximum dose because of what I mentioned earlier from patients who are septic. And then I just watch for side effects. I'd love to have TDM available here, like at point of care, but unfortunately I don't have. So, but this kind of gives us an estimation as to how well this drug has been cleared by the filter. Next slide. That's that diagram again. So after you calculate the pseudo-creatinine clearance, if you're falling here at 20 mils per minute, so 30 mils per minute or less than 10, then you can actually use all these doses here. But anyone that's on an effluent dose greater than 35, we've already calculated that one for you.
So we shouldn't be using creatinine clearance for real on filter patients?
Not on the filter, yeah. Because you're getting a fake creatinine from it. You use the filter's effluent dose. Thank you. Okay, quiz time. So get your pens and I hope the answers are not there. If the answers are there, then don't look at the answers. So what dose of meropenem would you prescribe for a patient who's 60 kilos and who's on CVVHDF at 35 mils per kilo per hour? So start with the pseudo-creatinine clearance, 35 times 60 divided by 60 is 35. And Amir, do you mind going back a slide? Just the one with the table. That one, yeah. And so meropenem is here, and then you go down there and you find this one. So you've got two options: 1 gram TDS or 2 gram TDS. Which one do you want to give? 1 gram. Depends on the indication. It's a trick question. So if you want it to penetrate the CNS, you give 2 grams. If you don't want it to penetrate the CNS, you give 1 gram. But yeah, you can give maximum dose. Thank you. And the next question, you can leave it like this because you can see both of them. What tazocin dose would you prescribe for a 77 kilo patient on CVPH-DF at 45 mils per kilo per hour with severe sepsis?
1.5.
Did you say 3 or 4 times a day? 4 times a day, yeah. So 4 times a day. I could give them more, I would give them more, but I don't, my hands are tied. But yeah, 4.5, 4 times a day. On the days that they're off the filter, then you can reduce it slightly to TDS or BD. On the days that they are on the filter, then you optimize it and increase it again. And the nurses are very good at like prompting as well and letting you guys know. Thank you. Next slide. Okay, so this patient is a 40-year-old man being treated for gram-negative septic shock. He's got 3 liters of normal saline, so that's like for resuscitation within 2 hours. And he's mechanically ventilated, receiving NORAD at 0.3 micro per kilo per minute. His urine output is good, it's 1 mil per kilo per hour, and his creatinine is 64, so the kidneys are working well. He has serum albumin of 25 grams per liter, and his estimated Cockcroft gold creatinine clearance is 116 mils per minute, so that's very high. So he's currently receiving Piptaz 4.5 grams every 8 hours as a half-hour infusion, and gentamicin 7 mg per kg once a day. And then here, can you just not look at the answer? I'm just going to have to cover it. Which one of the following factors most likely affects the probability of achieving a Cmax / minimum inhibitory concentration ratio of 10 for gentamicin in this gentleman? Is it A, the increased clearance to conserve renal function, because renal function is really well? Is it B, co-therapy with Piptaz? Is it C, the low albumin from fluid boluses and mechanical ventilation? Or is it D, volume expansion from fluid boluses and vasopressor support? Sorry, I can't do this. You've already seen the answer. And the answer is A and D, basically. Gentamicin, there's nothing, with gentamicin and piperacillin, there's actually like, with co-therapy, that doesn't increase the effect. That might actually minimize the effect. You shouldn't give them back to back, you should give them a bit separate. And it doesn't bind to protein, the albumin won't affect it. But you saw that the patient's renal function was really good, so there'll be increased renal clearance and possibly augmented renal clearance that we see in ITU patients. And we gave him lots of fluids, and he's probably also leaky, and that's why he's on NORAD. So there's probably like an increased volume of distribution, so that will lower your concentration. So we should optimize that. Even though you'd be worried about the nephrotoxicity, try and optimize the dose first and then worry about the toxicity after you get to level. Is there no way I can hide the answers?
I think you've got display settings, can you?
I think that's the right thing. Just make it
Yeah.
one. Yes, yeah, take this one.
Yeah.
Okay, good, thank you. Okay, next. Okay, so which one of the following is best to recommend to optimize Piptaz dosing and use the pharmacokinetic and pharmacodynamic target attainment in PE? So for tazocin, would we give 4.5 grams every 6 hours in 1 hour infusion, or 4.5 as a loading dose, as a half-hour infusion, followed by 4.5 3 times a day as an extended infusion over 4 hours? Or would you give a loading dose of 4.5 followed by continuous infusion of like 4 times 4.5 grams, 18 grams over 24 hours? Or would you give 4.5 grams every 8 hours as a 4-hour infusion, if we had the capability to give them?
See?
So it's definitely C. C is the right answer theoretically. But unfortunately, we don't have the protocol in place. So the next best option that we're using, A, yeah, thank you.
In reality, we do A, yeah.
In reality, we do A because we don't have the evidence in the protocols, but we're doing C. Okay, next, I'm going to talk about amikacin. Sorry, I'm taking too much time. I'll try and speed up.
No, just with that.
Okay, thank you. So amikacin is an aminoglycoside that stops protein synthesis. It's active against gram-negative bugs, including Pseudomonas, and some gram-positive organisms, but I wouldn't prescribe it for a gram-positive. And the usual dose is 15 mg per kg per day. It has poor lung penetration, so it's not good for like your VAPs and your HAPs. And it's treated in the urine unchanged by glomerular filtration. But it's contraindicated in myasthenia gravis, so you have to have a really strong reason to give it if you're giving it to someone with myasthenia, because it would exacerbate their symptoms. So the molecular weight is 585. It's not that protein bound, and it's treated unchanged in the urine, and the volume distribution is really small, and the half-life is 2 to 3 hours. But in renal failure, the half-life is prolonged. It can be up to 150 hours. And on the filter, the dose that's recommended is 7.5 mg every 24 hours. Technically, because of like the volume of distribution that you have, and initially there's an increased volume distribution, you can get away with the first dose being 15 mg per kg. The subsequent doses need to be 7.5 mg per kg. If a patient has a high BMI, we use something called a dose determining weight. And the next slide should show you the calculation, or no. So it's concentration dependent antibiotic. So the higher the concentration, the better the extent of bacterial cell death. And it's best at being above the MIC by 8 to 10 times. It also has something called the post-antibiotic effect. So that bit where you have no antibiotic in your plasma, it's still working, it's still carrying on to suppress bacterial growth. And increased concentration increases the post-antibiotic effect. And this has a synergistic effect of host leukocyte activity. Thank you. Yeah.
Why does this happen, this post-antibiotic effect? What is the mechanism behind it?
Haven't a clue. Sorry. I can look into it and get back to you. It's just a phenomenon that we see that it still carries on happening. I think maybe there's a bit more just lingering around in the cells.
If I'm not mistaken, post-antibiotic effect is still said to be an unexplained phenomenon, and it has been found in certain class of antibiotics, like azithromycin, and aminoglycoside, and tetracyclines, wherein the effect, both the therapeutic as well as the toxic effect, both of them last for a certain period of time.
Thank you. So distribution, it distributes poorly into adipose tissue. So if you have a high BMI, then we use the dosing weight, which is adjusted body weight. Elimination is cleared by the filter. The plasma half-life varies. As we said, but in renal impairment, it could be increased. In Burns patients and in patients, there's increased renal or extrarenal clearance from the huge fluid boluses. And with repeat dosing, you can get cumulative exposure, which might result in renal accumulation and toxicity, which is nephrotoxic and autotoxic. Next slide. So do you give normal dosage? Do you give higher doses? So we stick to like 5 milligrams per kilogram, but we stick to 15 milligrams per kilogram, but then do you give a bit more or less? We give based on like our therapeutic drug monitoring that we give. Ideally, we should review the dosing intervals. So if a level comes back high, we shouldn't reduce the number that we have. We shouldn't reduce the actual dose. We should just increase the frequency and skip a day and give a day, give it every 48 hours. 36 hours, the nurses do not like. But if you have to give it 36 hours, you have to give it 36 hours. And that way you get that peak and trough effect. This is how you calculate creatinine clearance. This is how you calculate the ideal body weight, and that's that dose determining weight that we mentioned. So the dose determining weight is the one I'll talk about, which you get the actual body weight, and you subtract it from the ideal body weight. And that difference, we only want 40% of it, and you add it to the ideal body weight. And this calculation, this sheet is available at the bottom of the renal sheet that I've given. And you need it mainly for drugs like amikacin and gentamicin and vancomycin as well. So we're going to do it today together. What's the dosing weight for a patient with an ideal body weight of 70 kilos and an actual body weight of 120? You do 120, take away 70.
90.
You just do that in your head. Okay, I think it was 90, yes, you're right. So it's 90, so it's 120 minus 70, you get 40% of that, and add it to 70, you get 90. Thank you. So depending on your renal function, you give different doses. So you can give the 15 mg per kg every 24 hours, or if it's 46 or 15 mg per kg every 36 hours. But as you can see, we're just sticking to 15 mg per kg as much as we can and prolonging the frequency to every 48 hours. Then when your renal function drops really poor, then they're reducing the dose just to minimize the peak effect. And if you're on the filter, 7.5 mg per kg every 24 hours.
So this is one where we're giving less when they're on the filter, we're not giving them the normal, even without filtering off.
Yeah, because the levels still come back high for some reason. So 7.5 mg per kg seems to be working on the filter. So we take a pre-dose level before giving the second dose, but we don't wait for the result to come. We always recommend to give the dose because the sepsis will kill the patient if you delay giving the antibiotic. So don't wait for the result. And you can take the level even up to 6 hours before the dose is due. And if the patient's stable, you don't need to monitor any more levels, like we cause anemia by taking too many levels. So you can just monitor them twice a week if they're stable and you're not too fussed about it. Your target is less than 5 milligrams per liter. If it's greater than 5 milligrams per liter, then we hold and we adjust the dose, and that's when you say hold. But the default is to always give. And you adjust it by increasing the frequency. And one stat dose does not need a level. If you give it a stat dose, just forget about it. Just move on. Next.
Is there any downside to giving like a 50 mg stat dose on someone who's got like crap renal function, like creatinine clearance of like 4 or 5?
So if you're not going to put them on the filter, it will cause their renal function to deteriorate. If you're going to put them on the filter, you can give a one-off 50 mg per kg. Because that one-off dose, it will be diluted with the extra volume of distribution. The safest dose to give is that 7.5 mg per kg, and it should reach a level that's less than 5. You can also take a peak level, which is 1 hour post-giving, and that will tell you if you've reached the peak or not. Okay, so we're going to do an exercise together. So we already calculated the dosing body weight for this patient. That's 120 kilos. With an ideal body weight of 70. So what's the maximum dose of amikacin that we can give? So do you want to go back 2 slides? It's in that one. So 1.5 grams is the maximum. So if you count whatever you calculate with the dosing weight, you can't go above the 1.5 grams. Back forwards again in there. Thank you. When do you sample a trough level for amikacin?
After the second dose. Before the second dose.
For the second dose.
6 hours.
6 hours.
Up to 6 hours, yeah. So anytime between 0 to 6 hours before. But the 6 hour window gives you time for the biochemistry to bring the result back. What do you do if your amikacin result is not available and the dose is due now? Yeah, thank you. And how much amikacin would you give for a 60 kilo patient who's on the filter at 35 mils per kilo per hour?
7.5.
Yeah, so 7.5 mg per kg. So if the amikacin level comes back high, do you reduce the dose or do you increase the frequency? Increase by, I mean, like prolong the frequency.
Increase the interval.
Yeah, increase the interval. Thank you. Next. So antifungals, fluconazole is of 306 Daltons. It's only 11% protein bound, so that's not much. It is excreted in the urine. It has a low volume of distribution and half-life is 30 in normal patients and 98 in end-stage renal failure. And in renal impairment, we technically half the dose. Whatever dose you wanted to give, just give half in renal impairment. But remember what I mentioned, next slide, about on dialysis. So on dialysis, not on dialysis, your kidneys usually have that tubular reabsorption where they reabsorb the fluconazole again. And this doesn't happen during CVD-HDF. And every hour that you have someone on CVD-HDF, it halves the fluconazole. So technically 5 hours and that fluconazole is out of their system. So that's why we try and optimize and give 800 milligrams if anyone's on the filter. Most people are on more than 2 liters per hour. Next slide. That's it. Sorry I took too long. Any questions?
With other cases, what's a bit weird about? So maximum, like, so you get to confused in doing levels when people just give stats here and there.
Yeah.
Like, say if you give a stat and then 2 days later you give another stat and then the next day you give a stat and it gets you out of sync, doesn't it?
So if you're doing that and you're doing one here and there and here and there,